Welcome to Medical Associates Health Check. I am Dr. Christopher Bristow. I am the founder of the Concierge Medical Clinic and a specialist physician in internal medicine. And my co-host today is...
Hi, I'm Dr. Laisha Selvaraj. I'm the clinical administrator for Medical Associates Hospital and the head of accident and emergency.
And backed by popular demand, we have our urologist, our consultant urologist, Dr. Adrian Ramkisoon. Welcome.
Good afternoon, guys. Pleasure to be here.
Nice to have
Thank you
you,
for
man.
coming.
So today's talk, we're going to be discussing kidney stones, right? That's a big deal because it's a pretty, popular and common problem that we will see across
Day in, day out.
across our practice.
That's true.
So, Dr. Ramkisoon, how common is common?
Well, kidney stones affects approximately 1 in 11 people in Trinidad and Tobago. All right, and that's international data. All right. Now, in certain parts of the world, for example, in the hotter territories around Saudi Arabia, Kuwait, Iran, or even in the southwestern belts of the U.S., kidney stones prevalence is up to 20 to 25%. That's because of the climate. Now, we live in a tropical country, all right, and we are a hot environment. So, yes, we have a high percentage. But to say we actually have a dedicated figure, we don't. We don't have those figures yet. But what we know is it's very prevalent.
Yeah.
Dr. Ramkisoon, who is more likely to get stones, men or women?
Well, that's a good question. Historically, men are the number one gender to get stones. But with everything in life and the need for gender equality, women are slowly creeping up on the men. And throughout the world, in the most recent studies, they have been noticing where women are actually coming up. So men prevalence of stones have stabilized, but women are slowly coming up. And I feel they're going to overtake us just now.
Much like everything else.
Yeah, definite. They'll just roll past us, with their stones.
But when patients, come and they say, "Oh, I feel I have a kidney stone,"
Yeah.
what does this look like, or what does this feel like for that patient?
Right. So, firstly, if you have a kidney stone, you may not even feel anything. Many kidney stones, irrespective of the size, could be asymptomatic.
Right.
So we have patients walking around Trinidad and Tobago with these big rocks, these big boulders that they took out of a quarry, and they have no pain. Conversely, we may have guys who have a small little stone, 2 millimeter, 3 millimeter stone, and these are the patients complain of pain. And what do they complain about? They may get pain, loin to groin pain. Your kidneys are located in your back, next to your spine, so you're going to get pain on the affected side, and it will wrap around your back and come down into your groin, right? That's one type of pain. You may get nausea and vomiting because the pain is so severe. Now, if you start to get fever, all right, chills, rigors, then it means that the kidney stone has caused an infection. In both cases, whether you have an infected stone or you have a non-infected stone, patients may complain about blood in their urine. And I like to tell my patients, imagine like this. You're brushing your teeth, your toothbrush, it misses your teeth, it hits the gum, it bleeds because it scrapes the gum. Likewise, the mucosa of the kidney gets scraped up with the stone, it's going to bleed. Especially if the stone is coming down the ureter on its way to the bladder, it's just rumbling and scraping, having a good old time, causing pain and scraping as it comes down the road.
So technically, kidney stone is a misnomer, right? Because it's really urolithiasis or stones that could occur anywhere along the urinary tract.
Correct.
Including the bladder.
So kidney, tubes, and the bladder we have to look for.
Yes, so it could be, the whole term is urolithiasis. If it's in the kidney, nephrolithiasis. If it's in the ureter, right? Most of the stones that form in the ureter come from the kidney. Stones that form in the bladder may either come from the kidney, come down the ureter, and form in the bladder. Or, as we discussed on our last episode, guys who have enlarged prostates will tend to develop a lot of bladder stones because they're not emptying properly and they have a lot of stasis of urine.
So, Doc, you talked about these people that don't feel pain. I actually find a lot of patients, or mainly female patients actually, will talk about a pelvic pressure that they get. How often do you see that with your female patients?
It varies. And it varies with size of the stone and the presentation and if there are any comorbidities associated with the patients.
So what does really cause the stone then? Like, what has caused it to happen?
So kidney stones, main composite. First, to understand what causes, let's take it back a step. What is a kidney stone. A kidney stone is a stone that is made up of either calcium oxalate, calcium phosphate. It could be a struvite stone, a uric acid stone, which you tend to see in guys who eat a lot of meat, right? So, or a cysteine stone, which is very rare. So you have this stone, and this stone forms, all right? And what puts you at risk for this stone? One, your diet. Whatever you eat could cause it. People who have a high BMI, those guys who are obese, are at risk of getting kidney stones. Also, those who are diabetic, hypertensive, suffer from cardiovascular problem, these are risk factors for getting a kidney stone. In addition, if you have a family history of a kidney stone, you will form a stone also because it's in your family. And if you had a previous kidney stone, like I tell all my patients after I do surgery and you clear them, once a stone former, always a stone former unless we change your diet. So if you had a stone and you passed it out or you had surgery and it was removed, you're going to form back a stone unless you change your diet.
So what happens to patients that don't consume a lot of water? Because that always seems to be a common association with kidney stones.
Yes, so dehydration is a risk factor in patients with kidney stones. That's why when we speak about the climate, and the southwestern belt and the hotter countries, is because one, we lose a lot of water in our skin due to sweating. We lose a lot of water when we breathe out. So in essence, the water that's left in the system for the kidney to filtrate is such a small volume that the urine becomes very concentrated. Now, all of us remember science class back in primary school, secondary school. You have a beaker of water and you keep throwing salt in it and stirring it. And after a point comes, the water cannot accept any more salt. And that's what happens. That's how we form kidney stones. There's supersaturation and a stone form, and it just starts to grow.
What is the biggest ever recorded kidney stone in the world?
Right.
Is it recorded?
Yes, it is. Unfortunately, it's not in Trinidad. It comes from Sri Lanka.
Okay.
And it's the biggest stone in the world. It came out of a 62-year-old war veteran. It weighs 800 grams. 800 grams is the weight of, and it looks the size of 4 baseballs. So when you watch this stone was measuring 5 point something by 4 point something inches, one big rock.
They managed to preserve that kidney?
Yes, they did actually preserve the kidney, which was amazing. There still was function in the kidney. And
Wow.
that's a amazing story there.
Yeah. And you mentioned once a stone former, always a stone former. Are there things that people can do to mitigate their risk?
Yes, there's a bunch of stuff we do. Like in terms of the metabolic prevention, after we normally recommend this in guys who have very small stones that are non-operable, or in patients who we have operated on, cleared you, we work on the metabolic side. What we do? We tell you straight up, you need to pass 2.5 liters of urine a day, which means if you're living in a hot country, try to drink 3 liters of water a day. Cut down on your oxalates, because when we test the urine after, and it's high in oxalates are the bad guys. Oxalates are found is readily common. Everybody likes spinach. Everybody like a bhaji, dal rice and bhaji. Highest concentration of oxalates. Oxalates are found in nuts, chocolates, raspberries. These things could cause this problem. In fact, if you Google foods high in oxalates, you will get a list in there that will be so exhaustive. You might say, I have nothing else to eat again. I just drink water for the rest of my life.
So it's more like moderation.
So it's moderation. Okay. So if you are a stone former and you have been tested and you have a lot of oxalates, high concentration of oxalates in your urine, we work on prevention by cutting down the amount and cutting down the frequency at which you eat the oxalates.
Okay. So don't go anywhere. We're going to take a quick break. We'll talk about more risk factors for kidney stones, and then we'll start to talk about the investigations. Don't go anywhere. We'll be right back.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back to Medical Associates Health Check. Before the break, we were talking about kidney stones and how they form, and we actually touched on prevention, right? Dr.
Correct.
Ramkasoon?
Yes, definitely. So recapping very quickly, I spoke about fluid intake.
Yep.
We will want our stone formers to take in at least 3 liters of fluid a day. Secondly, we spoke about getting your oxalates in your diet low. And oxalates are found in nuts, chocolates, bhaji, raspberries, potato, yam, certain types of beans. But other things, everything, but you want to keep the volume low, reduce your amount and reduce your frequency. Secondly, citrate. Citrate is something found in lemon, rough skin lemon, citrus fruits. This is extremely healthy and very beneficial. This is actually a natural stone inhibitor. So in patients who have kidney stones and after we do surgery, we clear them out, we put them on citrate. We tell them how to increase their citrate, either by taking apple cider vinegar gummies or by drinking rough skin lemon. If they can't tolerate those things, then they could drink potassium citrate in certain cases to help get the citrate level up. And the last one we normally modulate, second to last one, is your uric acid. Uric acid is found in meats. So patients who eat a heavy amount, consume a lot of meat, are at risk of forming stones such as uric acid stones. So if you cut down the meat, you will reduce your risk.
What about your little, your gym people that take protein supplements? Are they
Right,
at
so-
increased risk?
It does not really increase the risk, all right? Yeah.
Okay.
The evidence is neither here nor there too fro because it
So
depends
it's
on
actually
what
meat
type.
itself, not protein in general.
It's
Yeah.
more like the red meats.
The red meats.
Meat. Yeah. Another big risk factor, we tell patients, your calcium intake. This is probably the most important one. We have a concept in Trinidad and Tobago. If you have a stone, don't eat anything calcium. Don't eat no cheese, no milk, no yogurt, no nothing. And that's completely wrong. Because what happens is that when you ingest calcium in your gut, calcium binds to the oxalate in your gut, forms a complex, and you poop it out. Now, if you didn't eat calcium, anything with calcium in it, the oxalates in your gut will get absorbed. They get excreted in the kidneys. In the kidneys always has calcium because we are always turning around our bones. So it's going to bind to the calcium in the kidney. Boom, calcium oxalate stone forms. So I actually have patients who take calcium supplements, calcium citrate supplements, which is dual benefit. They get their calcium intake and they get citrate, which is natural stone inhibitors. So they do very well.
Okay.
So how somebody come in and they say I having pain, I feeling this, I passing blood when I pee. Sometimes I find I going too often, doc. And you think it might be a stone. Like how we would work up somebody like that.
Right. So if a patient presents like that, the first thing you want to do, you want to test the urine. You want to make sure the first simplest thing to do in the office is a dipstick, a urine dipstick. You can send it off to culture after, but the dipstick will tell you whether or not the patient has a urinary tract infection because a patient could present with a UTI with these symptoms. Secondly, if the patient describes a history of the loin to groin pain or a constant pain or pain in the area just above the suprapubic region, just in the lower part of the abdomen, you'll want to investigate. What is the investigation of choice? Yes, we know people could do x-rays, you could do ultrasounds, but the investigation of our choice is a non-contrast CT KUB. Simple, straight to the point, tells us all the information you need to know and could make a plan to move forward.
Didn't you recently have a patient that nearly lost a kidney because of a kidney stone?
Yes, it was
A young female?
Yeah, 23-year-old girl,
Yeah.
late in the night, on Monday night,
Yep.
came into the hospital. When we looked at the CT scan, the right kidney just was not lighting up. No excretion of the contrast, just wasn't lighting up. And she was having that pain for about 2 weeks now.
More than
How
that.
you manage to do it
Yeah.
with contrast? How you manage to do it with contrast?
I was just lucky.
Yeah, the left
Her
kidney
creatinine was
good.
normal, so I was
Yeah.
able to do it with contrast.
So the left kidney took over for the right kidney. Everything looked normal, but the right kidney just wasn't lighting up. I went in, I took out the stone, lasered it out, took it out, dropped a stent in, left the stent in for 2 weeks, took out the stent, did back a CT scan, perfect. Kidney lights up like a Christmas tree.
When you've got the investigation, you've done everything, you've got stones now. It's not just one stone. You have a quarry, as you like to
Nice.
define it as. But you have a sneaky one that's in the ureter there and a big one. And it's about 1 centimeter. What do you do for those patients?
Right. So That's a good question, because it's all about the state of the patient. If the patient is infected, meaning they're having fever, chills, rigors, if when you do the blood chemistries, their white blood cell, which is a marker of infection, is elevated, you're not going to go into this patient and do any lasering.
Yeah.
You could end up killing your patient. So what you do, safety first. You have an obstructed kidney, it needs to drain. Just like home, when you have your faucet and it fill up with hair, you have to clean the faucet. Same thing. You have to drain the kidney. How do you drain the kidney? You take the patient into the operating theater and you may put in a JJ stent, which is a very small, thin piece of soft plastic. Can't even use plastic because it's not even made out of plastic. One of those polymers. And what that does, that bypasses the stone and allows the kidney that's obstructed and infected to drain. Now, there are some rare cases where there may be gentlemen or ladies walking around with 2 centimeter stones or even 3-4 millimeter stones that don't allow you to stent them. So in that case, you might have to do what they call a nephrostomy tube, which is a small tube from the back straight into the kidney to allow the kidney to drain.
Yep.
Once you have settled the infection, then now you proceed to surgery 2 weeks later. What do? We don't cut open anybody anymore. Days for that have gone. Stone management, whether it be in the kidney, the ureter, or the bladder, is completely endoscopic, meaning very minimally invasive. So we go in through the natural channels, the urethra, up into the bladder, up in the ureter, into the kidney. We either laser out all the stones in the kidney or laser out the stones in the ureter. I like to take out fragments. Why I like to take out fragments? You need something to test. How am I going to change your
what
diet if
exactly-
I don't know what the stone is?
Correct, yeah.
Because half of the time, all them stones look the same.
Yeah.
So I take out some fragments, and plus patients like to see what you did.
Yeah.
So I give them their query. We send it to test, so we know it's a calcium oxide stone, a calcium phosphate. Where are we sitting? But that is generally the treatment line for those types of stones. Now, if the stones are bigger, 2 centimeters, 3 centimeters and bigger, or what we have floating around Trinidad called Staghorn calculi, where the stones actually map out to the whole inside of the kidney, then what we offer them is a combined approach. We will do the fancy scopes going up into the kidney, but we will also make a 5 millimeter, which is smaller than your fingernail, puncture on the side here, the flank, and go directly into the kidney. So coming in from the side and coming in from below, you are able now to completely laser out, remove all the stones and clear that patient of all the kidney stones. And most of the time, you could do this in one sitting. Because we do a lot of laser surgery in Medical Associates, our laser runs at a lot of high energies, and being in the kidney, you're allowed to run at high energies so you can get the job done efficiently, effectively, and safely.
So stick up in right there. I want to come back to that laser surgery that you offer in medical. We'll do that when we come back from the break. So stay tuned, guys. We're going to take a short break right now. We'll be back with you in a few minutes. Stay tuned.
Hi, my name is Gumti Pujadas, and I am 66 and a half years of age. I have always had, a little pain. Most of the time it will be kidney infection and it will be treated and pain will subside, and that continued until 2 years ago before I realized what was happening with me. I was advised to do a CT scan, and when that CT scan was done, they found out there was a 3.5 centimeter Staghorn stone in my kidney. The pain was so intense I couldn't even walk. I started to vomit and almost lose consciousness, and that is when I was rushed to the medical facility. And I was thinking, okay, maybe they will have to cut, but he started to explain the procedure where it will be just like a keyhole incision. I was so happy for that. When I visit Medical Associates, the staff, they were so helpful and caring, compassionate. They will visit me and make sure that I'm very comfortable in my bed. Whatever is needed, it was done. I am doing everything normally now, no pain. Happy to know that I could do whatever I want. All of my family, whether they eye, ears, nose, throat, whatever, pregnancy or whatever, they visit this hospital. So this is like a family, our family hospital. I feel comfortable here. The doctors, the nurses, the treatment you get here. I am happy that I chose this hospital to do my surgery.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back to Medical Associates Health Check. We were just discussing about the treatment options. Dr. Ramkisoon, I had a little thought here. I mean, sometimes you'll hear from patients, for me to have a surgery, do I need to have the stent first and then do the surgery for the stone, or I could just go to my...
That's a real good question, because a lot of patients come to you and they have these preconceived expectations or experiences about a JJ stent. And none of it is actually false. It's actually true. A JJ stent can be uncomfortable. And I tell people like this. I have patients who have had JJ stents inside of them and they run around the place. They go and do marathons. They go hiking. They go beach. And then there are other patients who have a JJ stent and they are in so much pain, they lie down on a bed completely bedridden. So for patients who need to have surgery preoperatively, majority of my cases, and I could say this very safely, we do not put a stent before the operation.
Right.
Okay.
Our equipment is tiny enough to fly up into the kidneys in a non-stented kidney.
Right.
Okay.
So, we're talking about non-invasive or laparoscopic, or in your case, for this kind of surgical approach, it's non-invasive, right?
Yeah.
So you're going through the urethra and up to the bladder and then into the ureters and kidney. What's a new thing for you? You are basically pioneered this laser type surgery locally. How you go about doing that?
Well, I will say what we do, we keep pushing the envelope. And pushing the envelope means we go smaller and smaller and smaller. So when I first started and when I was in my training residency, we were taught to do it with one size scope. And that was a kind of pretty big scope. So yes, you have to stent the patients to dilate the urethra before. But now, as technology got better, scopes got better. So now the scopes are even tinier. So that's why I don't need to stent a patient
anybody.
before.
Right.
And then when you're doing the PCNLs, now
Define what a PCNL is, because most people won't know what that is.
PCNL stands for percutaneous, which means
Through the
the
skin.
little incision in the skin. Nephrolithotomy. Nephro is Latin for kidney. Lithotomy means taking out. So it's a small little incision, this small, taking out stones through an incision on the side here. So when we first started to do PCNLs, I remember a standard PCNL, you will dilate the size of the tract. The incision was 1 centimeter. And that was standard. But now with tech, once again, tech has evolved. Now the size of my incisions are 4.8 millimeters, which is half of a centimeter.
Yeah.
So being smaller, and also the tech has even gotten more complex where they have added on things that we wanted. They have designed it. So suction devices. So while you're lasering the stone, instead of a stone running all over the place and gallivanting, you are sucking out the stone fragments at the same time, keeping them close to you.
While you're
So,
lasering.
while you're lasering.
Nice.
Which makes things a lot less complicated.
Well, yeah, it makes things less complicated. You get higher stone-free rates. And then also standard of care, we check the CT scan before the operation, map out every single stone. So if you are going in for 8 stones, 9 stones, or if it's one big boulder, 4 centimeters, we know exactly what we have. And you do it systematically. So when you're lasering, you laser systematically. You just don't go on laser and boom, 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 and take one big stone, turn them into 100 fragments, and then you realize, wait now,
You can't
how
pick
we
them
getting
up.
this out?
Yeah.
There's too much work to deal with 100 fragments. But you laser it in a systematic way that as you're lasering, pieces are coming out one time. So even if you have to stop, you know that, hey, I've completely cleared 75%, 80%, 85%, 90% of the stone, and then 100% of the stone. Because the best thing to do is to get 100% stone clearance.
Yeah.
That's the aim, that's the mission, that's the plan. I mean, sometimes in very, very rare cases, that mission could be very hard to get because you don't really know a patient's anatomy until you go inside. And some patients could have stones hiding in these little caves called calyceal diverticulums. And you have to go and do all these little fancy things to dilate it and go inside, get a stone, take it back out. So yes, there is a bunch of factors that we look at in clearing a stone. But once you put the laser in and with all the technology, you're able to get 100% stone clearance.
Have you ever had a very complicated surgery where you couldn't manage stone clearance?
There was one case that I did. The CT scan showed stone. Everything showed the stone. So it looked like a routine stone. And when I went in, I didn't find the stone. And here I am inside the kidney, like I'm in a neighborhood, driving up and down looking for the house number. And I'm driving up and down inside this kidney, and I can't find the stone. And I'm watching myself watch the screen, watch the kidney, put in contrast, lighting up the kidney, and I just can't find the stone. So then I went back and I went and did some adjustments to the CT scan and stuff. And the stone was actually buried in the tissue of the kidney.
Oh, wow.
So I had to laser open a piece of the tissue of the kidney, and then boom, like a child on Christmas Day, I'm watching this nice big stone. And I was like grinning like a child because I was like, yes, we get here,
But doc, I mean, all surgeries have risk, and there is some expectation that some people could have a complication after surgery dealing with these kinds of things. What kind of complications patients could expect or they should prepare themselves for after surgery, something like this?
That is extremely important topic to talk about because stones, first rule, stones have bacteria. Bacteria are not your friend. Patients could die from an obstructed, infected kidney. So if we are going in to do stone surgery, we want to make sure that the urine is clear. There are no bugs in there. If after repeated treatments of antibiotics, your urine culture still shows bugs, we may go under the cover of antibiotics, which I've done a lot of times. That's the safer thing to do. So you go in there, infection is a number one cause.
So with all stones, you cover them with antibiotics?
Yes. So then now, when we talk, so that is infection aspect of it. So you have to tell the patient, hey, so after the operation, you are going to be on antibiotics for 14 days. That is standard. We can't, it's not no 3-day antibiotic business. This is serious business. Good work is about good preparation, good surgery, good post-op. Bleeding. You will get some bleeding. In fact, I have yet to discover a patient who never had any little streak of blood or anything. Just equipment moving around, touching the tissue will cause contact bleeding. Some patients, we did a stone the other day in the ureter. The guy had a stone there for so long that the tissue in the ureter was growing over the stone like moss on a rock.
Wow.
So when you laser out the stone and you cut out all that tissue and everything, there's going to be some little fine bleeders, but it's going to stop because when you stent the system, it will stop. All these things will settle over the next 3 to 4 days. Stent symptoms is another thing we have to tell the patients about. Stent symptoms is that when you have a kidney that's stented, just as it's going to allow the urine to run down into the bladder, when you go to urinate and your bladder squeezes to pee, it's going to send some urine up the road. So you're going to get a little pain on the flank, and then that pain will subside as you're passing urine, and then you may get a sharp little zing in the front where your bladder is. So these are things we tell all our patients.
Yeah. You've given us quite a bit of information today, and I'm pretty sure we could talk about stones all day, but unfortunately, that's all we have time for today. Thank you so much for coming.
Thank you.
And sharing your expert knowledge. We hope to have you back sometime in the future, if you'll come back.
I'll come back.
Thank you very much for watching today. And just so you could always catch us on any of our social media platforms. That's Facebook, Instagram, YouTube. We're on Spotify now, so you can always listen to us on the go. And this month is December, and, Christmas is coming. So we have an extra treat. Later on in the month, we will have a Christmas special. So stay tuned and check us out then. As always, thank you so much for watching. We'll catch you next time.